A patient is prepped, unconscious, and breathing in a standard anesthetic gas. For most, the body remains relaxed, but in a specific subset of the population, that same gas can trigger a violent, systemic physiological reaction. This reaction is known as malignant hyperthermia, or MH. It is a severe medical emergency caused by a biological hypersensitivity to certain inhaled anesthetics used during surgery. The cascade of symptoms is immediate and aggressive. The patient's jaw and body experience severe, uncontrollable muscle rigidity, followed by a rapid, dangerous spike in core body temperature. Beneath the skin, the underlying mechanism is a total collapse of metabolic regulation within the muscle tissue. The muscles begin consuming oxygen and generating heat at a rate the body cannot sustain. Survival in this moment hinges entirely on a rapid diagnosis and the immediate administration of dantrolene. Dantrolene is a specific muscle relaxant that acts as a direct antidote by stopping the abnormal release of calcium inside the muscle cells. Because malignant hyperthermia escalates within minutes of induction, the window for intervention is narrow. Identifying at-risk patients before the first incision is the only reliable way to prevent a fatal outcome. Recently, social media posts have gone viral by circulating specific lists of surnames, claiming that anyone with these last names is at a high risk for malignant hyperthermia. The panic driven by these lists stems from a basic logical error. They conflate a human-made social naming convention with a strict biological marker. Surnames are fluid constructs. They change constantly through marriage, legal alteration, or adoption. A person's legal name on a piece of paper operates entirely independently of their genetics. As a result, millions of individuals who share a common surname possess absolutely zero biological relationship and share no evolutionary lineage. But medical reality operates on entirely different rules. Genetic risk cannot be adopted or legally filed. It relies strictly on the physical transmission of DNA from a parent to a child. Relying on a surname to gauge surgical risk lacks any scientific basis. It actively endangers patients by creating false panic in healthy individuals and a false sense of security in those actually vulnerable to the condition. The actual biological mechanism responsible for transmitting malignant hyperthermia susceptibility is a pattern called autosomal dominant inheritance. This means the mutated gene is located on a non-sex chromosome, and inheriting just one copy is sufficient to cause the trait. The core rule is straightforward. Inheriting the altered gene from a single parent elevates surgical risk. This confines the heightened risk exclusively to first-degree biological relatives. Compare this biological pedigree against a theoretical network of people who merely share a last name. A distant relative or stranger who merely shares a surname has no higher risk of carrying the malignant hyperthermia gene than the general population. Actual biological transmission pathways strictly ignore societal legal constructs like marriage licenses or a name change at the courthouse. True genetic risk is traced exclusively through blood and DNA mapping. The concept of a clinical surname risk list is biologically meaningless. If malignant hyperthermia is strictly genetic, the obvious question is why doctors do not simply run a DNA test on every patient before they enter the operating room. The answer lies in the clinical reality of hunting for a pathogenic variant. A pathogenic variant is the specific mapped genetic mutation that has been proven to cause a disease. Here are 100 patients diagnosed with malignant hyperthermia. Genetic testing identifies the mutation in only 55%. The remaining 45% have the condition but yield a negative DNA test. Relying solely on DNA screening creates a massive, life-threatening clinical blind spot. A negative genetic test result cannot definitively guarantee that a patient is free from MH risk. Genetic testing is a specialized tool used to confirm specific cases. It is not a universal shield, and DNA sequencing alone cannot guarantee a safe operating room. We also have to examine the inverse scenario. Consider the patients who do take a test and test positive for the malignant hyperthermia pathogenic variant. Possessing the mutated gene does not guarantee that a crisis will occur during every single exposure to anesthesia. A genetically susceptible patient might undergo multiple routine surgeries over their lifetime without a single incident, only to suffer a severe, unexpected reaction to the exact same gas years later. Because raw DNA data is unpredictable, hospitals rely on genetic counseling. specialized healthcare professionals evaluate a patient's DNA results to provide actionable, real-world medical advice. These counselors interpret the nuance of the genetic findings by placing them alongside the patient's current physical state and their family history. The gene's presence acts as a high-alert warning system for the surgical team. It dictates a change in procedure rather than acting as an absolute prophecy of surgical failure. Accurately interpreting genetic risk requires holistic medical expertise. Raw genetic data, when stripped of its clinical context, cannot fully protect patient lives. To understand how doctors actually prevent these crises, we have to look closely at the physiological aftermath of surgery, specifically the dangerous symptom of rapid, severe muscle breakdown. The formal medical classification for this rapid muscle dissolution is rhabdomyolysis. Rhabdomyolysis is a condition where damaged muscle tissue breaks down rapidly and releases toxic proteins directly into the bloodstream. While rhabdomyolysis is a primary hallmark of a malignant hyperthermia crisis, the symptom is absolutely not exclusive to it. A patient's muscles might break down due to alternative biological triggers, such as an underlying, previously undiagnosed inflammatory muscle disease. Other common catalysts include specific side effects from completely unrelated prescription drugs or separate muscular metabolic disorders that have nothing to do with anesthesia. Distinguishing an actual MH episode from these other complex conditions requires a multidisciplinary approach. It demands coordination between anesthesiologists, medical geneticists, and muscle disease specialists. Distinguishing the root cause requires tracing specific enzymatic markers and analyzing family histories. This complexity is why internet diagnoses based on a single symptom or a shared surname are fundamentally flawed. If surnames are an illusion and genetic tests miss nearly half of all cases, anesthesiologists need a different tool to protect the patient on the table. The actual undisputed gold standard of pre-surgical screening is the comprehensive clinical patient history. Before any procedure, the anesthesiologist's priority is aggressively questioning the patient regarding any past, unexplained complications during previous surgeries. Because of how the gene is inherited, this investigation must expand to include the specific surgical experiences of the patient's direct biological relatives. This historical data is the determining factor. It directly dictates the anesthesiologist's choice of specific drugs, the use of alternative techniques, and the deployment of specialized monitoring equipment in the OR. Any patient with a personal or direct family history of surgical complications must explicitly inform their medical team prior to any procedure. True medical safety is not found by searching for your surname on a viral list. It is forged through precise, evidence-based communication between a patient and their physician.